everyone, we're here with Matt in the local osteo facility in Hillsville. So today we want to talk about perimenopause and the linkage between shoulders and hips. First of all, I'm going to introduce Matt. He's going to tell us a little bit about himself, how long he's been an osteo, etc., etc.
Hey Hayley, hey everybody. Nice to see all of your audience. Well, I've been an osteo for 18 years. I wasn't ready for this question.
Sorry.
That's okay. No, let's do it. I've been an osteopath for 18 years. I know nothing else but dad jokes and osteopath. Really, that's all I do. I think one of the questions I get asked a lot is, what's the difference between osteopathy and physio? Did you want to ask me?
Yes. No.
Yeah.
Go. Yeah.
I guess the main thing is, at least at a university, osteopaths are taught a lot of sort of medical background as well. So we get a lot of hands-on techniques, we get a lot of sort of medical background. And the physios, they learn a lot of medical things too, but they really focus on I think, the rehab.
Yeah.
And much more evidence-based as well. So I think what happens over time is, as the physio gets a bit more senior and as the osteo gets a bit more senior, we sort of lean into each other's weaknesses a bit. So the osteo probably don't get as much rehab through the university. So most osteos will want to sort of lean into that with post-grad courses, which of course most osteos will do. And physios probably want to learn a bit more hands-on techniques, which like we get a lot of things like joint manipulation, things like that. So we all sort of level out over time. But to start with, if you get like a new grad, they'll have a good medical background, but their rehab might not be so good. Yeah. At least in the osteo world.
Yeah. So I've been coming to Matt for a while now. I'm constantly injured. Good business for Matt. And yes, I've never had any manipulation done. That's what you call it. We joke now that I'm a bit of a crack whore.
You're my favourite crack whore.
Thank you. So let's get back to it. So I have so many clients that have impingements, issues with their shoulders, and typically it's always their left shoulder. I could name probably 7 of my clients. So yes, ladies, it is a thing, and we want to talk about why it could be potentially linked to menopause. Why? Do you know why?
We are seeing that a lot, and there's always new evidence coming out as well about the linkages. But the main thing is it's about the estrogen. That's the main thing. As our estrogen drops, basically tendons are made up of a big collagen network, which crisscross. They form quite a firm and a slightly tensile strength. So then, as the muscles contract, the tendons really anchor onto the bone, and so we need that strong collagen fiber. Now, as we age, sometimes the estrogen just drop a little bit through the menopause. So what happens is those estrogen molecules actually bind onto the tendon receptors. Yeah. So they lock in, and then it produces more what's called tenocytes and tenoblasts, and there's the tenoblasts that produce the collagen. Yeah. So we need estrogen. Yeah. And so if you don't have that sort of remodeling happening, because all of our cells they do remodel. So our we have cell death and we have cell rebirth. Same with our tendons and skin, our muscle, our organs. So there's always this remodeling process. I mean, that's how we grow, that's how we sort of develop. And so as we get a bit older, that remodeling gets a bit skew where the rebuilding isn't quite as successful. And with the tendons, it is linked to the estrogen. And so that leaves women a bit more vulnerable to tendinopathies, tendinitis, tendinosis, and these sorts of tears. Yeah. The way to counter, of course, is a few different ways. The main thing is to load the tendon. So we need to do exercise. There are links with HRT. It's not really my field, of course. It's more for a doctor to talk to, especially a GP that does focus on menopausal health. It's really good to find the right doctor for that. And there's some good ones in Hillsville. We're finding with HRT there are some promising studies that it can help,
As in release it?
Help with estrogen levels. So it can, it can help. But we don't know for sure. We're still waiting on some more studies with that. But from what I'm reading, it is quite promising. But that aside, because there's other issues with HRT, you've got to weigh all the pros and cons, and everyone's different with their own personal medical history. And that's not my area. I can't really give advice on that. But what I can give advice on is exercise and the tendon health. It's really important. When you exercise, it demands more regrowth, just like skin. Like if you rub your skin or on your foot, if you get lots of like irritation on your foot, like on the heel, because it's constantly sort of rubbing on the foot, then you get more skin growth. You get like hardened, callous skin. So it's the same thing with the tendon. If you load the tendon, if you put good strength and weight resistance through it, it will respond in kind. And so you can counteract the lower estrogen, even if you don't want to do the HRT. If you just load your tendon, get it fit and get it strong, and put more loading through it, then and of course it has to be gradual. You can't just start with heavy weights from the start, especially if you have pain in your shoulder.
Going to say, so if someone, for instance, comes to me and they're like, "Oh, my shoulder's starting to feel a bit funny," is the correct path to go just kind of push through what you can without the least amount of pain? Or I know there's people out there go, "Oh, I don't want to do anything, my shoulder hurts." What would you say to that?
That's a good question, because we're finding, like as I graduated, the evidence was very different. The advice was to just rest and do nothing. But that's changed. With all the money in sports, $1 million athletes, people want their athlete on the field quicker. There's a lot more sort of research done in rehab. So now what we know is even if you do have a bit of an injury, if you still load the tendon within limits, it will promote the regrowth. It just demands more of those cells, those fibroblasts that I talked about earlier. Those tenocytes and tenoblasts. It creates more collagen. If you're demanding more of those cells, they will respond in kind. So even with an injury,
push through a little bit of
pain. Now, if you've got a big tear, you don't just lift 100 kilos to your shoulder. So it's just got to be within them. So the best doctor is your own pain and your own body, and of course your own fitness. You're quite strong. Say you're more athletic than if I had, say, a lady who's 75 years old and say a bit overweight. It would be a much more gradual approach. But for someone who's an athlete, you can do a lot more load through the tendon in an early phase of injury.
So, for instance, let's just say me or anybody that has been doing weight training for years. All of a sudden, go through menopause, my shoulder's starting to become uncomfortable. Would I still continue with the same weights that I'm doing, or just take it at my own? If I think I need to go lighter, go a little lighter, but I can keep pushing because I have had the history of past
that's really
training.
a question. So the first thing is probably to get a scan. We would need to know what we're dealing with. So if there are some shoulder testing, which I'll happily go through if you're interested, I can show you how we do test for things like impingement. Typically, if you raise your arm up, and it's inflamed at that point of about 90 degrees shoulder, what we call abduction, and some flexion. If there's inflammation, it can impinge those tendons and they get a bit sore. So that's what we call a provocation test. So if that's a positive test, it does lean to maybe a tendinopathy, maybe even a partial thickness tear or a full thickness tear through the tendon, in which case the rehab will be a bit different. If it's more of a significant tear and you don't have a history of any weightlifting, then we'd start with, even the first week it was really painful, we'd just do rest and recovery for a first week, and then the second week we'd gradually build up some loading through it, But if you're an athlete and you've just got a bit of tendinitis, then it'd be more in the bracket of pushing through it.
So pretty much we need to get a diagnosis first, and that's where Matt comes in to help diagnose what the issue is, and then I guess we then can go from there. So most of my clients have been training for 5+ years. They just don't know what it is. So they just really need to find out what it is to see how far they can, I guess, push. There's so many different things. There's like frozen shoulder. What are some of the things that it could
frozen
be?
shoulder is very common, and unfortunately that's also like another thing that can develop in peri and post menopausal women. And there's some simple tests that we can do for that, which would sort of lead. The first motion that gets restricted with frozen shoulder is what we call external rotation of the shoulder. Often people will present to me with, I can't even brush my hair anymore because it's that motion. That way, exactly. So that's the first test. I say, can you do that? Can you wave to me? Can you brush your hair? Can you scratch your back? Those sorts of things get compromised, and that's often a good sign. I can't brush my hair anymore. I think frozen shoulder straight away. And you see it over and over, age bracket, not overly active. But the best thing to prevent again, frozen shoulder is just moving your shoulder. It responds well to movement. We don't know why frozen shoulder happens, because not everyone who doesn't move their shoulder doesn't get frozen shoulder. But some people get frozen shoulder without much like immobility. It's really common after surgeries or like a broken collarbone, where they've got the arm in a sling.
Yeah.
And so now physicians are really sort of encouraging people just to get some movement through the shoulder. Even just some pendulums, some of those like elephant trunks, just getting the shoulder moving early in the phase is really important to prevent frozen shoulder.
Yeah, and I'm assuming the same thing will be with the hip as well.
Yeah, hip. Well, so we've got tendons all over our body.
Yeah.
So the classic old man injury is the grandpa sort of leaping off the chair to chase the grandkids, and they just sever the Achilles tendon right off the bone. It's a really, I sadly hear this. I don't typically see that because they're in hospital, but it's a common story. Yeah. So it's not just obviously men don't suffer a drop of estrogen quite in the same level, but men have estrogen as well. But there's weakness as we get older, just that remodeling process. So tendons are all over our body. We have them in our elbow tendons. The elbow is a really common one. Yep. That's of the lateral the forearm extensor tendons. And it's the same process where they attach on the tendons, sort of hook onto the bone, what we call the lateral epicondyle. Yeah. And that's involved in the backhand, like in tennis, or anytime we grip it like it contracts. On the keyboard, you're typing a lot, these sorts of things. So we get a lot of tendinopathies where we just see even just light exercises. I got it myself. Yeah. Boogie boarding with my son. Just gripping the board over and over. 2 foot gentle waves, mind you. I still felt like the king, mind you. But just doing 2 foot waves, just gripping the board all summer, that caused a tendinitis. Yeah. So that's where the shockwave came.
I was going to say, so I also have Achilles tendonitis and a few other things. So I've been getting shockwave. So definitely would recommend as soon as you get something like that shockwave, get onto it early, because that's one thing I didn't actually know about it, and I was about a year too late, I think. So get onto it straight away, definitely. All right, so is there some things that you can show me, demonstrate on me, that we can maybe, you can kind of, I guess.
Diagnose.
Diagnose, and then, whatever we need to do from that.
Oh, well, let's do some shoulder movement.
So we're going to diagnose the shoulder. Matt's going to go through what a positive test will be for a diagnosis of a shoulder.
Okay. Yep. So the most commonly affected tendon in the shoulder is, I'm sure we've heard of the rotator cuff. So there's 4 rotator cuff muscles. The most commonly affected one is the supraspinatus tendon. That's responsible for the first 30 degrees of our abduction. So as soon as we raise our arm up to the side, the first 30 degrees, it's all supraspinatus. So you hear about someone starting the lawnmower too quick, or carrying heavy shopping bags, things like that. So if you've got a brittle tendon, or a little bit more sort of vulnerable to a tendinopathy or a tendinitis or a tear, those are the sorts of things that can sort of trigger it and start it. So we diagnose by wanting to test for what we call like a provocation test. So the belly of the supraspinatus muscle just runs just behind the shoulder blade, just on top here, and the tendon runs underneath what we call the acromion, or the sort of bony part of the shoulder, and it anchors on the side of the arm here, what's called the humerus. So when it's inflamed, if you raise your arm up in the air just by yourself, you might get a positive test. You might get pain straight away. Yeah. If there's no inflammation in there, that shouldn't hurt. So I'm assuming there's no pain for you there. Right, so if there was a positive test, you might already be like a little bit sensitive. But we have other structures in the shoulder. We have bursas, we have the biceps tendon, we have the supraspinatus tendon. So what I would ask you to do is to raise your arm up to the ceiling. We're testing that supraspinatus right now. If that started to hurt, I'd be thinking, and I would follow it up with a little bit of poking around that supraspinatus tendon, and that's sort of about where it is, and you would say, ow, for a positive test. But your supraspinatus looks pretty healthy to me. And so we can test the biceps in a similar way. We have a straight arm out here, and I get you to raise up, push up, and if that hurts, that again, so we're closing that gap, what we call the subacromial space. So the acromion is here, and underneath, so sub meaning under, and the space, so subacromial space. So the space underneath that acromion, or that shoulder bone there, and as you raise up, it's going to close on all those 3 structures: the biceps, supraspinatus, and the bursa. I like to talk a lot, so interrupt any time.
No, that's good.
And so the bicep is now what we're testing. So you're going to be pushing up. You're going to be using that bicep to hold up against resistance.
Yeah.
And if there's any inflammation or tear there, you'd be feeling that by now.
Yeah.
And again, and if you did say that hurts, I'd do a little poke around the long head of that tendon, and that's absolutely fine. So bi meaning two, of course, it is. So the long head is here, and the short head is just what we call the coracoid process in there.
Yeah.
But the most commonly affected one is the long head of the bicep.
Yeah. So pretty much you need to be able to diagnose this to know what the forward steps are really. Because I'm assuming they are different, going to be a different process.
Yeah, that's right. And if it's just a mild pain, I wouldn't even refer for an ultrasound. I'd feel pretty confident that just between me and with the personal trainer, I'd sort of send to you and say, would you mind just doing some rehab exercises for the shoulder just to get them right? So I'd feel comfortable that we could manage it ourselves. If there's quite a lot of pain, or if it's an older patient, I'd be inclined to get a scan, get a better diagnosis or a prognosis as to how long the tendon might be uncomfortable for. The tendon doesn't have to be fully healed to feel better as well. You could have an uninflamed tendon and sore because you've done a lot of exercise. So there's no real correlation sometimes, even with arthritis, there's no correlation between the amount of pain you're in and the degree of arthritis. The things we can control the most are our muscles. And they're now telling us 4 to 6 reps is the best amount to really...
4 to 6?
4 to 6 reps.
Like heavy or...
Heavy. You should be cooked after 7. You should be cooked after 6. They're saying don't do the 7th, that'd be too much. So you want to be doing, but we don't do it straight away, So we build up to that. If you can do 4 to 6 and you're really kind of like you're going strong, and they're saying for postmenopause as well. They're saying this now, but you don't start straight away, of course.
No,
but that's the best way to prevent and improve tendon health.
Yeah, okay. So I do have a couple of clients that have just come back from frozen shoulder. It still hurts them. And we've slowly creeped up the weights back to where they originally were. It still gives them grief, but they push through. And they're going, I hope that's okay. I'm like, I hope that's okay too.
Well, actually, with frozen shoulder, it depends on the phase you're in. There's 3 different phases. If it's the thawing phase, it's the final phase, and that's where you start to get improvement. There's the frozen phase, which you can start to push through. If it's the initial phase, we don't want to push it, exacerbates. But if you're in that frozen phase, then absolutely, it's all about range of motion, and you can push through. There's a procedure surgeons do called manipulation under anaesthetic. Now,
Ouch.
It is. They knock you out, and then they literally wrench your shoulder around, and so you can force it yourself, but it's very painful. But the surgeon will spend a few minutes just literally in all directions, circumduct your shoulder in all motions, and then you come back. Personal story: I started to get a frozen shoulder in my left, because I'm getting old. I'm 50, and so I started getting some mobility, and I couldn't do that anymore. That was starting, even just that much of external rotation was starting to hurt.
Oh, wow.
I was cuddling my son on the couch, and he leant right back, and he wrenched my shoulder back. And I screamed and it clunked, it crunched, but god damn it.
It worked.
It worked. He fixed me. Yeah, it's just he did a surgical procedure.
Oh, wow.
Quite serendipitous.
Yeah, there you go.
Amazing. Yeah.
So, okay, that's actually probably gives a lot of people some comfort out there.
Yeah, if it's frozen shoulder diagnosed, and if you're in the later stages, you can definitely go for it.
Yeah, and look, we can do some things, myself being a personal trainer, there is things that we can do to help the process. So, for instance, like a neutral grip pressing, anything that's a little bit closer to the body in our neutral grip does help a lot. People that have shoulder impingements or whatever it might be, whatever the diagnosis is, we can do things like that. We can also put the bench flat or on a decline because it does hit lower chest fibers and stops getting so much into the shoulder and the delts. Anything that's overhead usually is a bit of a no-no. Even getting into a bit of a 45-degree angle is also a little bit uncomfortable for most people, but you still can do pressing movements and you can still work your shoulders without being in too much pain.
Incredible knowledge, Hayley. Any exercise, I'd be deferring to you.
Look, we can. There is things that you can do. I personally, I don't know whether that's your opinion, but I personally think the worst thing that you can do is go oh, I'm done. Nah.
Oh, absolutely.
Yeah.
The only time you're doing that is in the first week of quite a big injury where you've just got to rest. But it's with the vision of including exercise.
Yeah.
That's probably where I'd have the patient probably for a bit longer. I'd help them through the cotton wool phase.
Yeah.
And then when they're ready for the rehab, I'd be sending them on to you.
Yeah. Okay. Yeah. Okay. Well, there you go. So if you do have any niggle or pain or whatever it might be, I'm going to pop Matt's details down below on this video. Feel free to reach out, and I'm sure if you mention my name, he'll look after you.
100%. I want to put you on my Instagram, but I'm old. You have to help me out.
Oh, yeah, that's fine. We can do that. Thank you, everyone. Thanks, Matt, for your time.
Thanks so much, Haley. It's a pleasure.